Singh. Second speaker is Lieutenant Colonel Alok Sati. Yeah, please be ready with your presentation.
On this side.
On this side.
Yeah, you can come on the podium and just make it is working. Yeah.
So that we'll save
Keep
time.
1, 2, 1, 2 like this. All presentations are available on both sides.
And presentation is for 6 minutes. So timer should be for 6 minutes.
Now the timer is for 6 minutes for each.
Full. So, good morning everyone. I am Dr. Bhupesh. I am working as a corneal specialist in Bharati Hospital, New Delhi. So, I am going to present my paper on comparative outcomes of compression sutures with intracameral C3F8 versus C3F8 gas alone in corneal eye drops. The authors have no financial disclosures to make. As we all know that acute corneal eye drops is a corneal edema due to imbibition of aqueous humor into the corneal stroma due to tear in Descemet's membrane in extreme ectasia. The predisposing factors are VKC, younger patients and Down syndrome patients. There is a conservative management for managing this situation, and it provides symptomatic relief till spontaneous resolution occurs, which takes approximately 3 months. In this, topical steroids, antibiotics, cycloplegics are given. If we talk about surgical management, intracameral injection of non-expansile gases, sometimes sterile air, or 14% non-expansile perfluoropropane or 20% non-expansile sulfur hexafluoride is practiced worldwide. So coming to the purpose of the study, in this study I am going to assess the efficacy and safety of this procedure and to compare with the normal conventional C3F8 insertion. This is a retrospective intervention study from July 2014 to July 2016. 20 eyes of 20 patients with acute eye drops having stromal cleft underwent treatment. Patients were divided into 2 groups. In group 1, I did the compression sutures with C3F8 injection, and in group 2 C3F8 insertion alone was done. Preoperative complete ocular examination was done, and in all the cases AIOC2018 was done to know the cleft size. The presence of Descemet's membrane tear and stromal cleft were noted in all the cases. So this is a surgical technique. It is done under complete sterile precaution. 0.2 ml of isoexpansile mixture of 14% C3F8 injected into the anti-eye chamber under topical anesthesia. Then 2 to 5 full thickness compression sutures applied with the help of 10-0 nylon sutures. So this was one of the cases presented to me 2 years back, and this is a 17-year-old girl presented with corneal edema in the visual axis. She also gave the history of air injection 2 months back elsewhere, but there is no resolution in the corneal edema. So I went ahead and did a AIOC2018 to know the cause of this edema and found this persistent cleft. So I took up this case for the surgery. Volume. And we can see it's obscuring the visual axis completely. Volume down, please. So first of all, side port is made, and then C3F8 gas is injected. Make sure that pupil is constricted to avoid any damage to the natural crystalline lens. Then full thickness sutures are passed. The suture should be perpendicular to the cleft direction, and we have to identify the cleft direction on the slit lamp or on the AIOC2018. The procedure should be very gentle because this area is very weak, and rough handling can damage the lens also. So make sure that the AC is never collapsed while doing this procedure. The sutures has to be very tight, because if we put the loose sutures, the very next day the suture become loose and it won't serve the desired purpose. So it has to be very tight. The knot should be buried. So how this procedure acts? So this procedure acts by tamponade effects. It helps in the position of Descemet's membrane to stroma. It inhibits migration of aqueous into the stroma. It also squeezes out the accumulated fluid that is there in the stroma and promotes endothelial regrowth along the suture lines. And there is a resolution by minimal scarring. In postoperative care, a strict supine position should be maintained for 2 days. Oral acetazolamide tablets should be given for 3 days to avoid any rise in intraocular pressure. Pupil should be pharmacologically dilated till C3F8 gas is there in situ, and antibiotic steroid should be continued till sutures are in place. So this was a post of AIOC2018 picture. We can see there is no cleft remaining and the cornea is compact. And this is a post-op 3 weeks photograph of the same patient. We can see the visual axis is clear, only suture marks are visible. And this is a post-op 2 months photograph. We can see cornea is almost clear, compact, and another advantage of this procedure is that it also flattens the cornea. So due to which the visual acuity also improves with time. So this was another case of acute eye drops, same procedure done. And this is a day 1 photograph, and this is after suture removal. We can see the excellent results of this procedure. This was a recently operated case of acute eye drops. The cleft is very big and it's a huge corneal edema. And same procedure done. And day 1, we can see edema is almost 80% gone. So visual recovery just takes a week time in most of these cases. So coming to the results, the average age is 18 plus minus 4, and the male-female ratio is 12:8. VKC was found in 14 patients, whereas 2 patients had Down syndrome. So if we talk about visual acuity was significantly improved in both the groups, but it is more in cases of compression sutures group because of the flattening produced by the procedure. And the recovery time of corneal edema is around 16 days in most of the cases in compression suture group, whereas if we talk about C3F8 group, it is around 70 days. So there is a huge difference between the recovery time in both the groups. So 1 patient had pupillary block, and 1 patient had increased intraocular pressure, and 1 patient had recurrent eye drops after the suture removal in post-operative complications. In C3F8 group, 1 patient had pupillary block. So literature also suggests the use of C3F8 gas, and it shows that it takes around 78 days to complete resolution for the corneal edema. So coming to the conclusion, the compression suture technique is easy to perform and has less learning curve. No major intraoperative or post-operative complications seen. This technique helps in early visual rehabilitation and improves quality of life of the patient. Thank you.
Thank you, Dr. Bhupesh.
Is the responsible for this resolution, or the suture is the
So both help, but faster resolution suture is the main responsible for the faster resolution because it squeezes out the fluid immediately. So very next day you get 70 to 80% clearing. But definitely a position of DM always we require C3F8.
So what I want to say is that first day itself the resolution is happening. It is nothing role of a C3F8. One day the gas will also stay. Normal air will also stay for 1 day.
Yeah, but 1 day is not sufficient. Like this case that I shown the surgery.
No, you have shown that the first day itself almost 80% is gone. That's why I'm saying.
Because we have put the sutures very tight, so it squeezes out the fluid. But air doesn't squeeze out the fluid. It just gives the tamponade for the DM to attach to the stroma. But sometimes again the DM falls back because the eye drops are very big. So in small, if the cleft or DM break is small, we can go for the conventional treatment like air or C3F8 injection alone. But if the cleft or DM break is quite big on the
first case was there was a minimal cleft.
Minimal cleft, but it was already one procedure has been done, air injection, but no response in the corneal edema. That's why I taken that case for the C3F compression sutures.
Okay. Any case you have done repeat also?
So, yeah, one case I had I removed the suture at 3 weeks, but the very next day the eye drops develops again. So I have to put the sutures, and it's now 4 months, but I have not taken out the sutures. The patient is doing well.
So repeat suturing was done with C3F8 or without C3F8?
With C3F8. Yeah. So
Thank you.
C3F8 is must for the sutures because lens is clear, so we require something to make the AC deep. Yeah.
Thank you.
Thank you.
Any comparison without suture? Any comparative study have you done, or what literature says?
No.
Because I know even in a normal case of in the surgery, cataract surgery, if descemet detachment takes place, as I think if the air injection or sometime gas is sufficient, no need of any suturing, and position is variable.
Yes. So
because once it's attached, there is little chance for the detachment.
So in cataract surgery, the cornea is usually healthy cornea, but in cases of keratoconus, the cornea is already weak and ectatic. So attachment is not that easy as if you compare with the cataract surgery. So I think we require more compression sutures to get the results.
Suture and air will have the same effect as suture and C3F8?
I think C3F8 retention time is longer, so we get tamponade for longer duration. So I think definitely gas is better than air for these cases.
So optimal time of removal of sutures, as you have suggested, is 3 weeks.
3 weeks, yes.
But there was a recurrence. So would you consider making it 4 weeks to prevent recurrence? Would the increased duration of suture remaining there help you in preventing recurrences?
So we have to assess the condition at 3 weeks, how the patient is doing, how the cornea is compact, the attachment is nice. We have to do the AIOC2018 to see the condition. Then we take a call. It's not fixed that every 3 weeks you have to remove only. Sometimes 3 weeks, sometimes 4 weeks. It can vary patient to patient.
This is the only study that you have done. There are no other studies. This is an original study so far?
No.
Okay,
Yeah.
good. Thank you.
Thank you.
Excuse me. Which suture is better, 9-0 or 10-0?
10-0 nylon I put.
Any medical treatment before surgery?
So no.
No medical treatment. Straight
No.
away go for surgery.
Yes. So we have to do AIOC2018 to see the amount of cleft
Excuse
and
me,
DM break
excuse
size.
me,